but we opened in August 1st of 2019. And the goal was, number one, to bring it into regular medicine. Like I believe that when somebody initially presents, they have a medical problem and not a behavioral problem. I think if we can get the medical problem under control, we will convert that into a behavioral problem. And then the patient will have the ability to change their behavior without the force of the medical addiction.
Can you give me an example of what you mean?
If somebody comes in and they're on fentanyl, and you put them in a group, I don't think, they have to have some way of being maintained to a large extent. Like if somebody is there's no heroin anymore, we never see it. But the heroin statistics, if people stopped heroin cold turkey, within 12 months, the recidivism rate would be about 90%. If you use Suboxone, then the recidivism rate is about 40%.
I see.
Now we think at this point that we have a success rate around 70%, and there's a lot of things that go into why it's happening. A lot of issues, but like I just don't think that you can. You have to have some mental modulation, I think, for a lot of our patients. Somebody asked me once, they said, well, I just quit cold turkey. And I said, sir, you're a really strong man, and that's quite an accomplishment, but not everybody can do that. Right. And since we take Medicaid, a lot of our patients go home to a suboptimal home environment, to say the least.
Sure.
But we wanted this, to be a medical consultation in a medical facility, because it's not represented in that way. The whole theme in the medical world is we're operating in a triangle with the hospital at the apex and primary care at the base. Mm-hmm. And so in that situation, we're all trying to, primary care, specialty care, hospital, we're trying to prevent the upward migration. And but in addiction, they start at the hospital, so to speak. They start at the facility. And for the guy who's just has an alcohol problem, they're troubled in their marriage, they're not doing the job that they could at work or as a parent, there's no place for them to go, because to get an inpatient program, they're not going to be able to go away for any period of time. And I think that the other thing too is that it's a big commitment. Like if I were having a problem with alcohol, for me to go to a facility would be a huge decision. For me to get an addictionology consult, which is a lot easier. For the properly selected patient, it works great. We do IOP, OP, we do MAT, we do low-level co-occurring, and the reason for that is...
I'm sorry, if I don't understand a term, I'm going to ask you, what is MAT? I know what IOP is. But...
Oh, I'm sorry, yeah, MAT is medical assisted therapy with Vivitrol or Suboxone.
Okay.
And generally, so that medical assistant, we also have a designation MAC, or medical assisted consultation. And that's the term that we kind of made up on our own, because in that regard, we're taking people with alcoholism and using FDA approved medications to try, injectable Vivitrol or oral naltrexone, acamprosate, things like that. So they're coming in for medical reasons to use the FDA approved medications. So those MAT and MAC, we're using meds. And the co-occurring, one of the reasons why we do it is because we have a lot of Medicaid population, a lot of Medicaid patients. They have no resources. Like the likelihood that they're going to see a psychiatrist is almost zip. And so when they come in, anxiety, depression, PTSD, well, everybody has it. If they, it's a chicken or the egg. But the problem is, after going through addiction and some of the things that they went through in their lives, it's almost impossible, I think, to not have an element. But we want to address it and not ignore it. But if it gets to the point where it's not primary care level, and by primary care level, I mean, if I went in and talked to my doctor and I said, I have depression and anxiety, and they said, okay, well, here, we're going to give you an SSRI, that, they're not going to send me to a psychiatrist. No. So we don't want to ignore it, but we're not the experts in that field. But at any rate, just trying to make it approachable. It's a smaller setting. They see us all the time. I mean, we're incredibly dedicated to what we do. And I think the patients really feel that way. And then the other thing is, if you did the tour, it's a really beautiful looking facility. And I think like the point of that was to show respect to the patient. Like if you went into a cardiologist's office and it was a dump, you probably wouldn't come back, or you'd think like, gee, this guy must be struggling or something. But when the patients come in, like one of the Medicaid patients said, well, why do you do that for us?
Oh,
Why do you do this for us? Because they've never seen it before. And
oh,
our counselor said, like, a Medicaid patient spending 45 minutes with a doctor, like it never happens.
no, no. And also you're creating a sanctuary, you're creating a safe space for people. So it has to feel comfortable. When COVID started receding a little bit, what did you find in terms of the patients who weren't able to get detox or any care during the pandemic?
I think the number of people, the common story that we hear is, I was doing okay until COVID hit. Like I
Right.
hear that over and over and over again.
As do I.
If you have a beautiful home and you're quarantined in your home, well, it wasn't that much fun, I don't think, for anybody. But on the other hand, if you're in a small apartment, it's like being in jail. I mean, you can go to the liquor store, but you can't walk in the park, and you can't go to a gym.
And you're
But
stuck in the house or the apartment with people who you've been having conflicts with.
oh, yeah, absolutely. Yeah, I mean, family problems just got blown. I mean, not only did drinking go off, but now all the things that go with it in the home are massively accentuated.
So did people come back, really quickly once they could, or did it take some time?
We had a lot of problems because telehealth is very good in a lot of ways, but for our patient population, like they don't form the bond. They just don't form the same bond. And our entire organization is about forming that bond. Like I want that patient to have a bond with me. And that's a powerful thing, because it's almost like working with your kids. In the
Absolutely.
sense that if they trust you and believe in you, they'll be more likely to do what you want them to do.
Right.
And on telehealth, you'd have, people who were showing up, and trying to get a full IOP group was hard. Again, like detox, it's open, it's closed, it's open, it's closed. So we can do it, we can't do it. So how do you get out a consistent message to the community that we're a detox? It was very difficult.
Yeah, I would imagine. So you probably know that my area of expertise is assessing and treating adolescents and young adults. And
Yeah.
so I'm reading a lot about how teenagers these days aren't drinking or using drugs as much as recreational drugs, as much as they were some years ago. But also at the same time, their risk of dying of an overdose is going up. And so I wanted to ask you, what are the problems that you're seeing among young people? What is their most common addiction?
Well, I tell you, I think the amount of pot use, THC, is massive. We see anxiety and depression a lot.
Mhm.
The kids, I think, just don't know where to go. They don't know what to believe in. Smoking pot, or, now the latest is psilocybin. There's a lot of interest in that. Whether it be good or not, I don't know. They're doing research on microdosing LSD, but
Right.
but I think that the pot's a big one. Now the vaping, I think, you have the problem with popcorn lung and things. Vaping may not be maybe a big problem. It depends on what you vape too, but that's what I see a lot. Now the overdose deaths, I think, come to a large extent because they're going to increase just because it's fentanyl. And I don't remember the last time, heroin is metabolized into morphine, and we do the urines. I don't remember the last time we saw morphine, but we see fentanyl in everybody who
Really?
walks
So
in
there's
this
no
one.
more heroin anymore?
Nope. Nope. It's all fentanyl.
I know about 5 families who lost children, to heroin overdoses, and that's just gone. Now it's fentanyl.
Yeah. I mean, like I said, on our urines, we just don't see it. And when I opened up, it's almost 3 years, people, the big problem is it'd be heroin, fentanyl, and then boom, and that would kill them because they wouldn't understand what they were taking. And even if they were smart enough to carry around Narcan, if you're using fentanyl because of the long half-life, you better carry at least two and call 911 because you go down, you come back up, and then you go down again. And that's a big problem. But now all we see is fentanyl, and fentanyl is hard to detox from.
Why
It's
is
a
that?
challenge. Well, first of all, it stays in your system for a while. So if we're going to use the Suboxone detox, which whether they stay on it or not, it's called buprenorphine detox. But buprenorphine is a partial agonist at morphine receptors. So it'll bring you from here to here, and you have to wait until the fentanyl's out of your system. Because if you use fentanyl today and then I gave you Suboxone now, you'd have precipitated withdrawal. And because they took you down from 100 to 65 like in a minute. And that gets ugly. But the other thing too that we really worry about is by the time you make a decision, like we're open 7 days a week, and we'll see a patient within 24 hours because we believe if you've made a commitment to detox today, that doesn't mean that you're going to feel the same way tomorrow.
That's for sure.
Yeah,
sure. You're talking about like patients taking fentanyl purposely, but I wanted to ask you about something else that's going on. And that is that high school students and college students are buying drugs on the internet, particularly psychostimulants like Adderall. And I've been reading that many of them are laced with fentanyl. And so they're dying because they don't know that it's in there. Are you seeing that or hearing anything about that?
In our experience, there's fentanyl in everything. Like we say with the THC, you're smoking pot, you think it's pot. There's a good amount of fentanyl in those in the samples, because we'll have people come in and they just like, no, I just smoke pot, and we always try to push them. We don't know what to do about that, so we kind of turn our close our eyes to the pot, but they'll test positive for fentanyl on a urine, and that the person, and then if it's positive on a point of service cup, we'll send it out. So it is fentanyl, but they're really adamant about not using it, and I believe them. So it'll be in almost everything that you buy, or you have the potential to have it in there. So
do you mean even from stores that are selling THC legally, like gummy bears and things?
No, not from stores. I'm talking about buying it off the street.
Oh, okay.
That's what we'll tell people, like, get a medical marijuana card, or make sure you buy it from a company and not a drug pusher. But people will come in and say like, oh no, my weed guy is way cheaper.
Yeah, of course.
So they still go to the weed guy because, and I said, you better know him really well, because you got to know where this stuff's coming from.
They don't do that kind of due diligence. So I'm glad you're talking about marijuana, because this is a huge issue for me right now in my practice. Yeah. And I'm seeing that it's becoming worse and worse. And how can it not, when marijuana is becoming legal in many states, right? And the House of Representatives just passed a bill, I think last week, to decriminalize the drug. So I think that teens are getting the message that, oh, it's just like alcohol. It's fine. It's going to be legal. I can have it. And in my work, I see many teens for neuropsychological evaluations because they're not functioning well. They can't concentrate. They can't remember anything. They're less motivated. They're tired. They have no stamina. And of course, it turns out that they're smoking a lot of weed. So literally just this morning, I was working with a 17-year-old young man who has been getting high since middle school. Now he's failed his junior year of high school. And I just started this evaluation. So there may be some learning disabilities involved. There's certainly psychosocial issues involved with family. But how do I know if marijuana is a major contributor to this? How do I know, or other mental health professionals like me, know when it's time to refer a kid like him for an assessment or treatment?
Well, see, I think one of the important things is the more that more acceptable it becomes and the more legal protection it has, and kids don't see it as anything dangerous, and then the use goes up. I mean, there's
Exactly.
definite inverse correlation. But if you're using on a regular basis, and by a regular basis means at least 3 times per week, you're going to have the likelihood of getting a physical withdrawal syndrome or a substance use disorder from marijuana is 9%. If you're using it before 18, it goes to 18%. And I saw data at 25, if you use it every day, it's 25% among teens. So a lot
Mm,
of them have that problem. I think like the loss of 78 IQ points is definitely at least a consideration because
mhm.
they're on MRI, there are not only functional but anatomical changes in somebody who's smoking pot on a regular basis.
Where
And
are those
somebody
changes? Are they in the hippocampus where memory is, or in the frontal lobes?
hippocampus, yes. The rest of it, I don't remember well enough to say more. But I gave a lecture on. It was at Stockton University when They were all very in favor of THC, and I wasn't anti. I was just trying to cite facts. And the guy said to me, "Well, how do you know if it's observational or causational?" I said, "Well, that's not my job." I said, "It's your job. You're advocating for something that whether it's observational or causational, I mean, you have to prove that it's not because before you start, really pushing kids into this realm." But I think, it's just the amotivational syndrome is just
Oh,
terrible. Regular users, I don't see how they get any good out of it at all.
I
And
don't,
then if you look at a meta-analysis in New England Journal a couple of years ago, it didn't have efficacy for anything. Like refractory seizures were the closest in neuropathic pain. But
right.
an FDA study has 2,000 patients in it, and for refractory seizures, they had 13 studies with 900 patients, so they were moving in the right direction. But so they didn't see enough evidence in the meta-analysis to use for anything.
Wow, that's so interesting because you hear
Now,
so different now. Pain,
well,
sleep, all kinds of uses.
Well,
Interesting.
there may be more, like I said, there may be more data or more articles, because I've always said, if I see the article that really shows me that it was a case-controlled study and you had adequate power to the study, and it shows those results, okay, well, I want people who have, neuropathic pain to get relief,
Right,
right?
right.
I'm not a warrior against it. I'm just saying that you just have to show some proof. And if you're using it for pain and oncological, for oncological purposes, I don't care if you use
Yeah,
heroin there because
right,
the
right.
person's dying of cancer.
Right, exactly. So I'm going to switch gears for a second because I'm very interested. One of my other areas of specialty is working with women and women's issues. And so I'm very interested in what you're seeing in terms of gender differences with addiction. I've been reading that teenage girls are catching up to their male counterparts in lots of good ways in terms of STEM, achievement and such, and certainly getting into colleges and grad schools and professional schools. But I've also read that girls are catching up to boys in ways that we don't want them to during adolescence in terms of drug usage. I'm just wondering, I know you don't treat people under 18, but in terms of emerging adults, what kind of gender trends are you seeing?
If you're talking about who I see, like in the closest age group that I can analogize with, like 18 to 21, I
Right.
think it's almost 50-50 boys and girls,
That's
honestly. And I don't see much of a difference. I mean, the big issues with the girls that you really try to work on is, you ask to use oral contraceptives and no, and I'll try to say, well, having a child is a really, really challenging thing, and overcoming a drug addiction is a really, really challenging thing, and you don't want to do the two of them at the same time.
right.
Like, the other thing that we really have to test for is STDs. Everybody comes in, we're checking for Hep C, we're checking for HIV, and we're checking for syphilis, because that's another thing, like you don't want to miss it because tertiary syphilis is not curable.
No.
And for me, like, I'm being a gastroenterologist too. If somebody has Hep C, we treat them here for Hep C.
Mhm.
But the other thing too that you see is the girls, either they're in bad relationships.
Right.
There's a lot of prostituting themselves to get money for drugs, or they may have somebody who is feeding them the drugs just to keep them, tied to the the person who is, in most of the time that we see, a much older individual that will have the young girl and then buying her drugs so
Oh,
that she stays with him, and to try to get her away from the guy is sometimes hard,
yeah.
especially if he's supporting them if he's spending a lot of money on them.
Oh, absolutely. They're so dependent and they have no one else to be dependent on usually. They're vulnerable in the first place. So as a physician, are you seeing that girls or women metabolize drugs differently? Is there some, because I've read that it's easier for women to get addicted to things, certain drugs, than men. Is that true?
Well, the one thing that is, very well studied, the one substance is alcohol, which is very true. Men have more gastric alcohol dehydrogenase, and that's, if I drink a drink, part of that drink will never hit my blood because of gastric alcohol dehydrogenase. So
Hmm.
men have more. Now, if you look at a standard drink, which is 6 ounces of wine, 1.5 ounces of hard liquor, or 12-ounce beer, one standard drink will raise the blood alcohol level in a man by 0.02. It'll raise the blood alcohol in a woman by 0.04. So
Oh, right
twice
on
as
the
much.
problem. Yeah.
And then the man's bigger, and a man has a bigger liver too. But if you take that, like, it's kind of impressive. Like, if a man has 6 drinks in 2 hours, then you get to 0.12, you metabolize two of them, you're at 0.08. Okay, you're at the threshold.
Right.
Now, if a woman has that, she's 0.20, because she's 0.04 times 6 is 0.24. She's metabolized, you only metabolize, whether you're a man or a woman, one standard drink per hour.
Right.
So in the 2 hour period, she will knock off 0.04. And so it's 0.20 versus 0.08 with the same amount of drinks in the same amount of time.
That's huge. That's
Oh,
such a
yeah, no, it's
difference.
really huge.
So alcohol is another topic that I deal with all the time, as you can imagine. And since I do so much parenting guidance, parent guidance, I want to know your thoughts, because I see parents who occupy the whole spectrum. There are some who say, my child is not going to have a drop of alcohol till they're 21, and then they firmly bury their head in the sand. Then there are the parents who say, I want to be around when my kids, try alcohol. I want to teach them how to use alcohol responsibly. So I'm going to give them a sip during holidays. And then you have the parents who say, here is some money for beer, or here is the beer for your party. Just make sure your friends give me their car keys and they sleep over here and anything goes. And then they go upstairs and go to sleep, and God knows what happens. So with all those different things, what kind of advice do you give parents in terms of how they can best prepare their kids to drink responsibly?
Well, if you can buy the beer for the party and then go to bed, I mean, you could find yourself in a criminal case. I mean,
Which
there's
many parents,
yeah,
yeah, I
that
know.
is that is no joke. I mean, you do
I
not
know.
want to do that at all.
I'm aware of that. We've had many
Yeah,
examples of that in the community. Yeah.
zero's better than some, and some is better than a lot. But it depends on. In my mind, there's two types of drinkers. One is the partier drinker who's out, who having a good time and everything. Now you have to be careful because something dangerous could happen to you if you don't know who you're with. Don't
Yes.
get in a car, use an Uber. There's so many physically dangerous things could happen to you or other people if you're in that situation. And the other kind of drinker is the drinker who sits at home by himself and drinks, which I think is a massive problem.
More
And
of a
if you
mental
see,
health issue than.
yeah, if you see a kid doing that, like, I would be concerned not only for mental health, but I'd be worried about suicide. And I'm not that type of professional, but in
Yeah.
you know, my opinion, I'd be very worried if my kid were sitting on a couch drinking alcohol by himself.
Yeah. Do you have any thoughts about drinking on campus? Because there's a lot of controversy about how much responsibility schools need to take and how hard to come down on drinkers, and especially with fraternities and things. Where are the parents responsible? Where are the campuses responsible? I mean, what are your thoughts about that?
I think it's incumbent upon the university to have an alcohol policy, and I don't think you have underage drinkers. How could you possibly have a policy that allows for it? Like, I don't know if
Oh,
that
no.
you
Yeah,
could come up with a policy, but then if once you have a policy, you got to enforce your policy.
right.
And so I think you have a no drinking policy, as all schools do. So now you have the policy, you have to enforce it. And I think there's the possible negative is the kids so often just go off campus, but I don't see any other way around it, how the university can say, yeah, everybody's getting blasted at the fraternity every Friday and Saturday night, but I didn't see it.
Right,
You know?
right. They sometimes ignore it. So my last question is something that I'm seeing more and more of in my practice, and I suspect that you have the same issue. And that is, I have many parents who come in and they tell me these heartbreaking stories about young people, and they're over 18. So whether they're 18 or 19 or 20 or 23, whatever, but they're really struggling with mental health problems and with substance abuse problems. And of course, once they turn 18, their parents have very little way of influencing them. And the parents are just heartsick because they feel so helpless, and they're watching their kids sort of go downhill, and they don't know what to do. And so I'm wondering what advice you give parents when they're in that situation.
That's a difficult question because, initially I think you're going to be, I mean, I think one of the hardest things you could possibly do as a parent is turn your back on your children. But sometimes you have to, when it starts, you're going to do everything you can to try to help the kids. But eventually, it's not working if you're enabling them to the behavior. But I mean, I don't know, the first thing that I would say is, you might be 18 years old, but you're not really anatomically brain-wise an adult till you're 24. And so you're really not an adult, and you certainly, for most kids that are 18, you're certainly not an economic adult.
Right.
So I said, the fact that you hit 18 doesn't mean a whole lot to me. So I'm gonna try my hardest. I don't know. Think as a parent, your gut says I got to be there. I got to try to do what I got to do. But if you're going to give them a free home and they're going to have some spending cash and they're going out and using it on drugs, eventually you're going to have to cut them off.
Right.
And it's in their best interest to do that. But it would be, in my mind, the hardest thing that I could ever do as a parent, just to cut them off and kick them out of the house and maybe never see them again.
That's exactly right. Parents feel like they're giving up on their kids, and it's hard for them to understand the difference between loving them and enabling them.
Sure.
You know, it's
Yeah.
it's very, very difficult.
I couldn't imagine it.
I know. I hope we never have to, because I wouldn't
Yeah.
imagine it. Well, thank you. Is there anything else that I didn't ask about that you think it's important for mental health professionals to know, or parents of young people to know?
Well, I think with parents is you have to know what's going on in your child's life. You have to, if they have friends, if you can not only know the friend but know the parents. Like, you have to be active because there's a lot going on. And I think, as far as mental health professionals, if you alluded to Adderall back then, it's very important that, if you have a proper diagnosis of ADHD and you put somebody on Adderall, you will then decrease their future likelihood of a substance use disorder. But if they don't have the right diagnosis, then you'll increase their chances of a substance use disorder. So, the bottom line is the patient, the kids, the patients should be in the proper hands. The parent should put the kids in the proper hands so that the right diagnosis can be made and the right treatment can be undertaken. Because otherwise, drugs are self-medication. So if they're not treated professionally, they're going to self-medicate, and that's not going to go well.
Well, it's interesting that you say that. I mean, you're preaching to the choir about attention deficit disorders, because what I'm seeing is a lot of parents kind of want the medication to raise their kids' grades. And so
Yeah.
shopping for a diagnosis, and invariably, honestly, like I'd say like 60 or 75% of the students who come to HD evaluation, I don't see it. And almost
Yeah.
always some underlying problem that the parents don't want to acknowledge, or no problem that their kids just aren't superlative students. And the problem is the parents are pushing the ADHD. And what you just said is very interesting to me, because I know of, they're all three in their 20s. These are young men, all of them, who got diagnoses of ADHD when they were in childhood and adolescence. And they took Adderall specifically, all three of them. And interestingly, all three have developed psychotic disorders, and all three of them are addicted to Adderall.
Yeah. Yeah, well,
Yeah.
that's that's the one thing I would say. I know you want your kid to get into Harvard and everything, and you want those SAT scores, but you will increase the risk of a substance use disorder down the road that could be absolutely tragic. I
Right.
mean, amphetamines are powerful. If you look at, if your normal arbitrary dopamine level is 100, sexual activity would bring you to 200. So it's reinforcing. Cocaine will bring you to 400, and methamphetamine will bring you to 1,200. So
Oh
if
my
you look at,
gosh.
if you look at stimulants, they're very reinforcing, and they're not good
Oh, interesting.
unless you need it. If you have the right diagnosis, then like I said, it'll lessen your chance down the road.
Isn't that interesting? It's interesting how
It's
nature works.
fascinating. Yeah,
Yeah.
well, methamphetamines it not only augments the release of dopamine, but it blocks the reuptake. So it does two things.
Ah,
Like cocaine only augments the release. It's not a reuptake inhibitor, if I
right.
remember correctly. Cocaine's one of them, and meth is two of them.
Yeah, that makes sense. Way back, like decades ago, my neuropsychopharmacology. So thank you for reminding me of that.
Yeah.
And thank you for talking with me. This has been
Thank
great. I
you.
learned so much.
Oh, I appreciate the opportunity. Thank you.